there are academic or professional ecosystems, if you will. There's the ecosystem of the primary care providers, family practitioners, general pediatricians, internists. There's the ecosystem of the specialists, the individuals who have formal training in pediatrics or medicine, and then they become subspecialists. They go an extra 2 to 3 years of specialty training and to be hematologist. And then there's the ecosystem of those who sign the death certificate. Now, that ecosystem is unique because you can be a coroner without any medical degree who signs a death certificate and assigns attribution of death, or you could be a pathologist, or you could be a forensic pathologist, a subspecialty within pathology. And so that the information across these three ecosystems regarding the implications of having sickle cell disease and having sickle cell trait do not have the same amount of data and knowledge as to the evidence and the lack thereof of events surrounding death in roughly 8% of the African American population, which is the percentage of the people in the United States who are of African descent who have sickle cell trait. So it's not a trivial group of people, and as you can imagine, it's clear that there have been misinformation propagated in each one of these domains that I just described, or ecosystems. And as a group, we elected to, in the hematology domain, as members of the American Society for Hematology, a systematic review was commissioned, as they commissioned multiple systematic reviews to look at the evidence to support or refute certain medical facts. And those were the two questions that that the panel was charged to address. I should say one other comment is that in the ecosystem of the people who sign death certificates, that's pathologists, forensic pathologists, and coroners / medical examiners, what we found was that what we've known for since the mid-70s, that individuals with sickle cell trait would be labeled as having death attributable to either sickle cell trait, sickle cell crisis, or both. And the individuals who specifically provide medical care for children and adults with sickle cell disease have not been in the arena to. It's not our professional responsibilities to assign death per se, and so we have recognized and even within the field of pathology, they've recognized since the mid-70s that the presence of sickle cells after death is artifactual, not factual, and so there's been a conscious thread of or a deliberate thread of literature disputing these observations in the medical literature, in the pathology literature, in the pathology textbooks. And despite those findings, we still continue to have individuals who are held in custody, having as part of their attribution to death being sickle cell crises or sickle cell trait, which we wanted to once and for all review the literature to either support this diagnosis or refute it and describe the absence of literature to support and an explanation for why this is being reported erroneously since at least the mid-70s. The three most important findings are that there continues to be ongoing misinformation about the implications of sickle cell trait and sickle cell disease in the community at large. And there's a sense that the medical community and the primary care community, the hematologists, and the pathologists have to redouble our efforts to educate uh, our trainees, our graduates from our schools and fellowship programs, residency programs and fellowship programs about the terminology and the difference between sickle cell disease and sickle cell trait. We have failed to communicate to individuals at risk, individuals with sickle cell disease and sickle cell trait, to distinguish this the adverse outcomes, none of which include dying of sickle cell trait as a direct cause or indirect cause, or dying from sickle cell crisis as a direct or indirect cause. That's number one. Number two is that we found no credible medical evidence in the literature and no clinical experience among the vast number of hematologists who were part of the panel that sickle cell trait or sickle cell crisis should be listed as a cause of death. And third is that we do need to understand the full spectrum of complications that may occur in individuals with sickle cell trait. And this research is just beginning to be undertaken. There are significant complications associated with sickle cell trait. They are rare. We don't understand exactly why they occur. We do know that individuals with sickle cell trait are at risk for a complication that may occur in individuals with sickle cell trait and without sickle cell trait, and that's exertion rhabdomyolysis. And what's not mentioned in the manuscript, but what we do acknowledge as well, is that rhabdomyolysis may occur as a result of physical altercation. And this is when you have destruction of the muscles and the content of the destruction of the muscles are released. This can occur in a crush injury, such as in a motor vehicle accident, when someone's in a car or a motor vehicle hits an individual, and it may occur as a result of severe physical battering. When rhabdomyolysis is identified in an individual with sickle cell trait, the cause of death is not the sickle cell trait, but the presence of rhabdomyolysis, which can occur in individuals without sickle cell trait. But to underline, bolden, the cause of death is not sickle cell trait or rhabdomyolysis. I mean, it's not sickle cell trait or sickle cell crisis. It's the sequelae of the crush injury or the muscle injury that occurs in individuals with or without sickle cell trait. I'm optimistic that the primary care community of providers, the hematologists, and the pathologists can now come together and correct the lexicon associated with death, and that we will no longer attribute death to sickle cell trait or sickle cell crisis based to an expected postmortem artifact of seeing sickle red blood cells in an individual who has died because of the obligatory decrease in oxygen concentration, which results in sickled red blood cells.